finish up with our toxicology lecture, and then I will open it up for tiny review, only because I give you that check on learnings, and then answer any questions. Get you guys squared up for test next week. So, no laughing matter, ectopic pregnancy. This is a pretty big deal. This is definitely more of your lane with what you should be concerned about as primary care PAs, because you're going to be having women that are childbearing age. Very, very concerning. So 5 to 6 pages, chapter 98 out of Technology, edition 9. Here is your objectives, pretty much following the standard as we discuss things. Very low threshold to order pregnancy tests on patients. Now, are majority of patients going to have taken a pregnancy test at home and come in and tell you absolutely? Absolutely. So, differential diagnosis of child from the childbearing age. So, be on the lookout for this. If they have gone through a menstrual period, then you need to get a qualitative answer sheet. So, in most ED settings, I would say you should be doing a lot of this in your primary care. It's not just concern for ectopic pregnancy, but if somebody is pregnant, what do they need to be on? They need to be on prenatal vitamins. Most importantly, folate, so they don't end up with neural tube defects and have a kiddo that's not 100%, because that's about what anybody wants. They want a kid that has a working brain, 10 fingers, 10 toes, all that stuff. So even if I have a patient come in and it's kind of an incidental finding, they didn't think that, I am not going to counsel them on whether or not they want to abort the pregnancy. I'm going to make sure that they leave with prenatal vitamins, that is folic acid, of course. They can make that decision another day, but they're at least, if they're already pregnant and they weren't on prenatal vitamins, they're already behind the power curve. Pretty behind the power curve. So, ectopic pregnancy, when we consider that, having abdominal pain, that can be with or without vaginal spotting, but amenorrhea, 1 cycle at least, which can be different for every woman based on whether they have menorrhagia, metromenoragia, go through cycles, whatnot, for whatever reason. We always get concerned if they're having those symptoms along with lightheaded, syncope, or diaphoresis. Very concerned for an ectopic that's about to rupture. So, you have all these things right there that are differential diagnosis of pregnancy. Only one I want to specialize in there, so you look at all these different differentials. What is a heterotopic pregnancy? Not everybody is fully aware of what that is. What is a heterotopic pregnancy and who's at risk for that? So heterotopic pregnancy means they have a normal pregnancy, but they're having an ectopic as well. They're pregnant in 2 different areas. So yes, it's usually related to fertility disorders, absolutely. Not always IVF, because IVF, they usually do a pretty good job of making sure that they put the eggs into the uterus. Usually it's got a little bit more with fertility medications, things like Clomid, whatnot. So very concerning, that's why pregnant patients always get these types of histories on there. That differential is pretty huge, pretty huge. The amenorrhea can kind of give you an idea of that. So, ectopic, specifically by definition, is when it occurs outside of the uterine cavity. Now, what's concerning about this, why this is no laughing matter, this is leading cause of maternal death in the first semester of pregnancy. And this does get missed occasionally. It was missed on somebody very near and dear to my heart. So it does get missed, and it's pretty sad when it gets missed because it can be fatal. So, want to know these risk factors. So some of these risk factors. History of PID. Any idea why? Well, there's scarring of the fallopian tubes from infection. Scarring of the fallopian tubes from infection. History of surgery, true sterilization. Any instrumentation in there is going to affect that. Conception with intrauterine device in place should not happen, but if that does happen to occur, they got obviously amazing swimmers. and the swimmers make it all the way to the fallopian tube. So, unfortunately, maternal age, there are more assisted reproduction techniques. So, whether that's turkey-based technique, I'm not sure if the medical term is that IVF, things like that. Previous ectopic pregnancy is probably number one. They've had a previous ectopic pregnancy. And then smoking, because it alters embryo tubal transport, and then if they had any pharmacologically induced abortion. We'll talk about what the treatments are for those. Little pathophys for you. So fertilization, and that's pronounced oocyte. Oocyte usually occurs in the ampullary segment of the fallopian tube. So it passes along the fallopian tube, implants into the metrium in the uterus. So any other location in the uterus, the fallopian tube, extratubal sites, and even the abdominal cavity, cervix, and the ovary, it has happened, very uncommon. We're at a risk of that rupturing and then maternal death from exsanguination. And obviously, this is not a viable pregnancy, so mother and fetus. So majorities are in the ampullary portion, so that's just in the fallopian tube. So what happens, previous infection is damaged, the transport just does not occur properly, does not make it from the fallopian tube into the uterus where it's supposed to be implanted. So other causes, this person's had a tubal surgery, there could be some defects in the ovum, so the actual egg, that cause it to implant prematurely, and then a lot of these have to do with just hormone levels, estradiol and progesterone. If those are not at proper levels, that cannot migrate properly. Now we have these other things, abdominal and ectopic pregnancies, not very common. These are less than 1%. I just want you to be aware that they are out there. Similar predisposing factors. You can look at those. Some of those are similar there as far as previous ectopic pregnancy, instrumentation, but you have some other types of things within in vitro, previous cesareans, D&Cs, it's usually from a what? An abortion. They have to go to a D&C. There's any fetal rings left in there, and infertility. So, patients with these can develop profuse vaginal bleeding. But if you do a bimanual exam, you guys will do some RTA lab, you should know how to do a bimanual exam. When you do a pelvic, at least in the emergency department, we're not doing pap smears, we're doing pelvics, which is simply viewing the uterus, viewing the cervical os, taking samples, usually wet prep, KOH, sometimes gonorrhea committee swab, and then you're going to do a bimanual. Very important. Checking for cervical motion tenderness, which is indicative of PID, right? Want to make sure you know that going on. And then we're going to palpate the adnexa. Because if you have some tenderness to the adnexa, we need to be very concerned for ectopic pregnancy. We should see nothing's really different with the uterus when you palpate that, and diagnosis is obviously made in ultrasound. We'll take a little bit of time on a certain slide to explain how important our lab values are. But when you get an idea how their menstrual cycle's been, most of the time these are abnormal shapes. It's very difficult to pin these down. The classic signs: they've had no menstrual cycle for 4 to 12 weeks. So that's in about 70% of the cases, 7 out of 10 cases. So unfortunately, makes it a little bit more difficult. 1 to 2, around there, have no missed menses. So just be aware they can have scant, but they can have heavy bleeding. Does not mean it's going to be different for every patient. We get that. So what's pregnancy history? What's the easy way is you gotta know 4 different things. So my acronym I always remember is Florida Power and Light, full term, preterm, full term, living children. Florida Power and Light. That's just how I did it. Got a lot of different acronyms, even for 9/11 medevac. It's crazy. It's just how I remember stuff. Obviously, make sure, like we do for OSCEs, past medical history, medications. Definitely getting very into if they had some fertility. So everybody knows fertility doctors are pretty much OBGYN endocrinologists, right? They've melded those two and understand FSH and LH and all that stuff. So sexual activity, using a contraceptive. So ID risk factors. Anybody remember those risk factors from that previous slide? Cigarette smoking, older age, any type of tubal surgeries. What else? Previous ectopic, PID. So remember those. So again, if they've had a tubal surgery previously, now that's usually tubal ligation. Now they do a couple different things based on how they got that done, but essentially they had their fallopian tubes removed, or they purposely scar them in. There's a couple different ways that that's done. You just need to know, did they have tubal surgery or sterilization with the intent of sterilization. Now, if a person has an ectopic, a lot of times the doctor will go ahead and take the tubes as well, because that's number one risk factor, right? So go ahead and take the tubes and never have to worry about ectopics again. Can they still get pregnant if you take the tubes?
With help?
Yes. Yes, with help. Yeah. And it's just in vitro in the future. Or it doesn't mean they can't get pregnant again. Just so. Now there's been, weird stories where fallopian tubes have re-anastomosis on the ground. Not very likely, but we should assume that to be an ectopic. And then any type of tube ligation, and that's burning that, or they do remove it, that's a salpingectomy, is when they remove the fallopian tube. Less than 24 years after the procedure. High risk. Only time those people can be taken off the list is if they've had a complete hysterectomy. That's hysterectomy where they remove the ovaries as well. That's oophorectomy. So that's hysterectomy with oophorectomy, so they removed everything. So they're saying if we just do a hysterectomy, there's still a possibility. So, it's exceedingly rare, but still a possibility. I've never seen a case like that, but somebody's got to have a case study out there. So, abdominal pain, most common symptom or discomfort. Sometimes that can be misconstrued in a patient that has had previous pregnancy. She's saying, well, this is just my normal pregnancy pain. See, expanding of the long ligament, so they might get that confused. But obviously that's due to tubal distension or rupture. And if it's inside the tube, then it's going to be much more of a visceral type pain, so it can be a little bit more crampy, not necessarily until it starts to start to rupture, causes more inflammation, and then gets peritoneal, and we're in over her. So, classic pain of the rupture, so it's going to be lateralized one side or the other based on where that is, sudden, severe. Some of these folks can report some shoulder pain because that can be inflammation of the diaphragm that radiates up to the shoulder. That's referring pain. And we need to be considering these lower, usually below the umbilicus, left or right sided, lateralized. We need to be thinking woman of childbearing age, ectopic pregnancy should be the thing you need to be taking off the plate right away. So again, they do not have to be bleeding. Just have to be severe abdominal pain. Most women that have had a previous pregnancy will say that ectopic is much, much worse pain. Make sure we're paying attention to those vital signs. Right, so if we get rupture land, we need to be ready to jump on that stuff. Make sure we're checking all that stuff. Adnexomasses. Vital signs are very important, so make sure they're stable. Just be aware if that patient's bradycardic, we talked about the Cushing's response, blood in the abdomen can cause bradycardia. Sounds weird because they're bleeding. It should be tachycardic. Vagal response to blood in the abdomen. That is a vagal response to blood in the abdomen. That can happen with anything with blood in the abdomen. Just be aware of that. So, no fever, stable vital signs. It just has some rupture yet. Okay. Again, we look at that cervical motion of tenderness. Kind of want to take a look in there to see if there's any bleeding or where the bleeding's come from. Is it bleeding from the cervical os? Is the cervical os open? Is there anything sticking out? So again, checking for adnexal tenderness. The last ectopic that I caught in the emergency department, right adnexal tenderness, had a quant high enough transabdominal ultrasound. Right-sided ectopic was about to rupture. Straight to the OR. Straight to the OR. You're not going to see too much from uterine size. Very common for the cervix to be what color? Blue. Don't be surprised about that. It's not cyanotic. It's just normal. And then exam, we need to be getting a ultrasound. Most of the time it's going to be transvaginal, but we will get into that here. I'll explain all this stuff. That has a lot to do with these HCG levels. We have to go down that road. So HCG levels rapidly should rise 9 to 10 weeks of pregnancy. So if these are declining, I don't like delivering that news, which is why in the emergency department I'm likely just going to get one quant, so I don't walk in telling the patient that she has a miscarriage or a threatened abortion, which is a medical term, because I have a snapshot in time. But just realize if it's a non-viable pregnancy, that HCG is going to start decreasing. That's why a lot of these ladies that come in, if we can't figure anything out, I say 48 hours, come back to the emergency department. We're going to repeat it, but sometimes there'll be GYN says, we're tracking it, we got it, tell them to go to the lab and then come up to labor and delivery, we'll handle things. So, lower in pathologic pregnancies. So, again, no single HCG is going to give you an idea of that. That's just a snapshot of time. As long as it's above 5, they're pregnant. Okay. Doubling times longer in ectopic pregnancies. So lower and slower. And then spontaneous abortion, we're going to see a drop in 21 to 35% within 2 days. So you have an idea of that, what's going on. We'll get into a little bit more here in a minute about that. What's our primary goal with this? We want to make sure that they have a viable intrauterine pregnancy. So viable usually means cardiac activity is an exclusion for ectopic pregnancy. We need that confirmed, a viable intrauterine pregnancy. Now, does it get a little funky if they've been on fertility drugs? Yeah, and you need to let that ultrasound tech know, hey, I'm really concerned. I want to make sure this is not a heterotopic pregnancy. Can you please just take a closer look around? This patient's been on fertility medication. Very concerning. Right there. Heterotopic. We need to make sure, let that ultrasound, when you put in that water for ultrasound, patient has been on fertility treatment, whatever that is, whether that's medication, whether it's in vitro, whatever. Any assisted efforts of fertility, higher risk for heterotopic pregnancy. Even with that IUD. I might even just call up OBGYN and say, hey, it looks like a viable intrauterine pregnancy, but can you just real quick look at the ultrasound images for me? Real quick, just look at that. So. Sure, so for other patients, IUP, if they're not using fertility treatment, you pretty much rest assured that that's a sure thing. So, no other abnormalities, ectopic pregnancy can be excluded. So again, cardiac activity. We have to have cardiac activity. See, intrauterine pregnancy, cardiac activity. You should be able to put that into M mode if you're doing the ultrasound. Most of the time, send mode for a formal. Put that in M mode, and you're going to get a heart rate out of that. What's the normal heart rate for a fetus? Roundabout? 140, 150. Right around there. Here's where it gets wonky, and here's where some people have trouble making the jump here. This is called the discriminatory zone. This is why when we have somebody come in with an ectopic pregnancy, we are going to get a quantitative, not qualitative. Qualitative is yes or no. I don't need yes or no. I need quantitative. That's going to tell me yes or no. But scholars are going to give me a number. They're going to give me a number. So if I have that, I'm going to show you in the next slide what those number cutoffs are. But if I have another discriminatory zone, is going to determine whether they're transvaginal versus transabdominal. If I have above that certain level and there's empty uterus, I have to assume it's an ectopic pregnancy. I have to assume it's an ectopic pregnancy. And this will make a little bit more sense. I'll show you this next slide. So I need an HCG quantitative, to be at least 1,500. If it's 1,500 and it's below 6,000, I'm going to do a vaginal ultrasound or transvaginal. And usually the ultrasound tech is going to call over and say, hey, just want to confirm it's between 1,500 and 6,000. That means between 1,500 and 6,000, if we don't find an intrauterine pregnancy, it's an ectopic pregnancy. Now, if it's above 6,000, we can do a transabdominal. If we don't see intrauterine pregnancy, a fetus in the uterus, presumed ectopic pregnancy. Everybody clear on that? That makes sense. Below 15,000, or below 1,500, not so sure. Not so sure that you're going to see anything. What do we do with those folks? I usually call OBGYN and they'll say, oh, just tell them to come into the emergency department in 48 hours. We'll repeat the HCG, repeat the ultrasound. Sometimes OBGYN will say, you know, we're not busy. Tell them to just go to the lab. We're tracking who they are and then come up to labor and delivery and we'll have one of the docs do an ultrasound. Either way, that person's coming in 48 hours to get a repeat. Now, have they found intrauterine pregnancies as low as 600? Yes. But this is a discriminatory zone. If it's above 1,500, you're doing an ultrasound and you don't find intrauterine pregnancy, you need to be calling OBGYN. It's an ectopic pregnancy. They can figure it out from there. Get consultation. No visible intrauterine or extrauterine pregnancy. Get consult on the phone. Everybody tracking on that. Track. Okay. Look it over if you have other issues. So, this is this crazy algorithm. I'm not 100% big on algorithm-based medicine, but it is a good chart to give you an idea. What I see with this is ultimately this chart goes round and round and eventually needs to get an ultrasound. Needs to get an ultrasound. Now, if you're doing point of care ultrasound in the emergency department, will do those for some patients. If they've already ruled out an ectopic pregnancy, they've already had an ultrasound that says intrauterine pregnancy, I will just show mom and reassure her that she has a viable pregnancy with a fetal heartbeat. Now, keep in mind, this is a big, huge military thing, and I can't tell you how many pregnant women come in, or they just found out they're pregnant, they come in and they know exactly what to say. I've been vaginally bleeding, I'm worried about an ectopic. It's out there. You know what they get? They get a full workup, and they get to find out if it's a viable pregnancy and the baby's where it's supposed to be. They get what they want. But I can't tell you how many times I've been vaginal bleeding, I do my pelvic exam, and not a single bit of blood in the vaginal wall. But the word on the street is that's all you got to say. So you get a lot of workups. I do like probably, I'd say every shift, at least 2 or 3. Where I have a pregnant patient or vaginal bleeding that I get to deal with. That's great for the phase 2 students, and I'm like, you get to get some procedure time. You're doing pelvic, let's go. Just let you know that's more, I've been working like downtown Seattle, would not see a single vaginal bleeder or pregnant person for a month. But it's more of a militarism. So be ready, be smart on this, be ready to rock and roll. And don't miss it. So MRI, not likely, but just be aware that is a potential option. I would say probably not from the emergency department, but if you're inpatient, they can't rule in or rule out. There's potential to get an MRI done. Potential to get an MRI done. So, just to give you an idea of what they used to do back in the day, very archaic. They used to do a coldocentesis. It's essentially like a DPL, diagnostic peritoneal lavage. They just stick a needle in and then suck it out, they got blood. And assume it was a pregnancy or an ectopic. And the laparoscopy is useful in selling the diagnosis. The diagnosis is suspected, but they can't rule it out. So that's not your decision to make. That'll be for OBGYN and get them involved earlier than later. How do we treat that? We treat it surgically or medically. So laparoscopic salpingostomy, that's where they're going to go in. They're going to take out the fallopian tube that has, hopefully, unruptured, or with the fetus in it, and more than likely are going to take the other fallopian tube just because of the risk. So most frequent medical approach is going to be systemic methotrexate. I don't make that decision in the emergency department. I let OBGYN tell me they're going to do that. Methotrexate is very painful, and you're basically inducing an abortion. I'm going to let them make that decision because that ectopic pregnancy has got to be pretty close to the uterus if you're going to use medication to expulse it, versus it's way in the fallopian tube and you've got to go and take that out. So very painful. I'm going to let my consultant advise me exactly. I do that, aka OBGYN, and then they're going to need to follow up with that. Now here's the other piece of the pie that's very important when we're dealing with any type of ectopic, specifically with vaginal bleeders that are pregnant. We have to get the RH factor figured out. Are you familiar with that? A lot of these ladies come in, they're vaginal bleeding. I get like CBC, I get a UA, I get an HCG quant, and then I will typically have to order their RH factor. Why? Because if they're RH negative, they require alloimmunization. Everybody familiar with that? So RhoGAM, and they used to give a smaller dose for earlier pregnancies. Now it's just a standard 300. You don't have to worry about how far along they are. That RhoGAM is not for that particular pregnancy. It's for pregnancies in the future. So that the mother, if the father was RH positive and the mother's RH negative, so her blood does not attack the fetus's blood. The fetus comes out to be positive. Don't figure that out. We just make sure if you're negative, you're getting RhoGAM. If you're a vaginal bleeder, you're pregnant. Very, very important. You do not want to miss that. Full dose, 300 micrograms, usually an iron. Everybody familiar with that? A pregnant patient, if you don't get an RH, I don't necessarily always rely on the fact that maybe they put something in wrong. So be aware that those things do happen. That usually causes a PSR, patient safety report. Because not too long ago, I had a lady come in and said she was 12 weeks pregnant. I got her quant back, 0. I'd already sent her over to ultrasound, because she already had it confirmed that it was a viable pregnancy. I sent her over to ultrasound just to see if the fetus was still alive. I called the tech and said, don't let your face tell the patient anything. I get a report back. Fetus is just fine. I sent another quant down. The next one came back, 14,000. I printed up both of those and dropped it off to my chief. Somebody screwed up in the chain of custody of the blood. But I'm trying to make clinical decisions, and I figured this lady's probably already lost her baby. That blew my mind, I'm sure, and I submitted that patient safety report, because you can't screw that up. You can't have the wrong stuff down. You have a troponin go down on somebody and it's the wrong person, and now you're putting them into the cath lab. So just be aware, something doesn't sound right, it doesn't look right. You did do a really good investigating. I don't know if the nurse mismarked it, I don't know if it got switched up at lab. Either way, can't let that stuff happen. All right, unstable, obviously there are IBCs, our ABCs going. We need to get massive transfusion protocol, rock and roll. Large bore IVs, I told you, 14, 16, 18 is not considered large. So we need to be able to get that quantitative. Qualitative is just going to be a yes or no. That's typically done by urine. A quantitative is done by blood. Quantitative is done by blood. So, come on. Let's see what else here. So, consultation with the university department right away. That's proven ectopic. That's pretty much all I see on the phone. 24-year-old, looks like she probably got a right-sided ectopic. Patient stable, can come down and see the I don't want to hear all of it, they just want to get down and get it done. So, again, they're stable. We're unable to determine, we can't prove that it's extrauterine, we can't prove that it's intrauterine. It's too early, the HG is not high enough. 2 days, 48 hours, typical turnaround for that. What about we get a D-dimer and it's positive, they're complaining of leg pain, ultrasound is negative, how long do they come back in? In a week. Just giving examples of when you tell people to come back, get a repeat lab, get a repeat ultrasound. DVT, the D-dimer is positive, come back in a week with that scan. 48 hours for indeterminate pregnancy. All right, check on learning, and then get you folks moving. It's a very sensitive subject, so keep in mind, not so much for the females in here, but for the males, you don't have the anatomy for that, so have some empathy when we're talking about that, especially if you have somebody who's had multiple bouts of miscarriages coming in and like expecting bad news and whatnot. There are times where I will call OB/GYN down because the person's had like 8 miscarriages. Can you please come down and talk to them? They feel much better that coming from an OB/GYN now from male emergency medicine PA. Just food for thought. Those can be very, very tough times. Any questions on ectopic pregnancy? Pretty simple, right? So instrumentation of the abdomen, not necessarily around there, it's not effective, but PID, and the sad thing about PID is usually men are more symptomatic with that. A woman can have PID, and it can just cause significant scarring inside, no clue what's going on, and just puts them at risk for ectopic pregnancy in the future. So be aware of that. Which should lower your threshold for checking people for those types of things. It's not just your UTI, or maybe not just a fungal infection, maybe not just a bacterial vaginosis. Again, cast your wide net, catch those things. I told you we don't just willy-nilly methotrexate on our own, pick up the phone. General surgery, they don't have anything to do with ectopic pregnancies. Now, if this was appendicitis with a pregnancy, maybe general surgery might ring in. So obviously with OB/GYN. So we're not going to wait for an outpatient IV antibiotics or Jesus. We need to get an emergent laparotomy. Why? Free fluid. Free fluid is likely blood. In other words, this has ruptured. I know a lot of these seem easy now, but it's all different when you're in the hot seat on test day, right? Oral boards in the emergency department, you're fine sitting off to the side like, I gotta do anything, and you're in the hot seat, whole different ballgame, and you're on the spot. So what I say, if it's previous tubal ligation, is ectopic to improvement of rest rate. Ectopic to improvement of rest rate. Now this one's slightly different, you can take it, but you definitely know that discriminatory. Sure, I'll go back and check. We'll hit a review next week. Quick one. I get crazy. I'm not just going to rattle off 50 different things you should know to make that easy. All right, hang around for a few minutes if you have any questions. Otherwise,